Happy snowy Thursday to many of you. Jennifer Pelaggi and I are delighted to have you join us today. This is the first in our 4 Pillars of Prevention webinars, and it is called Avoiding Using Catheters When Less is More, Best Practice Indications. So the 4 calls really are grouped around these 4 items. The first being avoidance, which is our topic will be today. The next call next month will be about inserting with confidence. The third call will be in March, and that's about maintaining with care. And the fourth call in April will be all about removing promptly those unnecessary indwelling catheters or those that are no longer necessary. And I guess I should pause a moment and just let everybody know that we have gone ahead and muted lines. There will be an opportunity to have rich discussion and sharing towards the end of the call. And my colleagues will be monitoring the chat box, so you can feel free to chat in any questions you might have along the way, and we'll address those as we can. So today's agenda will mirror what the agendas of the future calls look like as well. We're very committed to starting every call with a patient story to get us grounded into why we do the things we do. We'll take a brief moment to just touch the highlights on best practice around the topic. So today's topic is around avoiding insertions. We'll touch briefly on those best practices as outlined in the guidelines. And then we'll move into the meat of the call, which is really having hospital colleagues share their story, share their approach to today's topic. So today we'll have 2 speakers from 2 different hospitals, one in Idaho and one in Washington, but they'll both talk about how they're approaching avoiding unnecessary insertions. We'll then open it for discussion, so folks can ask questions of those speakers, can pose questions to the group at large, can also share their experiences and how they're approaching. After that, we'll sort of segue into a request and offer period, and then we'll close out with a talk about what's next in the series. With that, I'd like to hand it over to Jennifer and Stephanie Martin.
Hi guys, this is Jennifer, and I'm really excited to have you all on the line. Thank you for taking time out of your busy schedule today to join us. We're just going to start off with a patient story. Tina and I will be talking a little bit today, giving some brief overviews of the best practices around CAUTI prevention. But these calls are really set up to hear from the hospitals that are doing the best practices, having those hospitals share with their peers across Idaho and Washington, and to have their voice and their practices be heard. So you'll hear less and less from us over time and more from the people who are in the trenches doing the same work that you're doing, who have tools and practices and policies that you can use, and they're willing to share them. And as Tina said, we're kicking off with a patient story. We're trying to bring the patient voice into much of the work that we're doing in patient safety and quality improvement. And I want to thank Stephanie Martin from St. Luke's Magic Valley, infection prevention practitioner there, for being willing to step forward with a patient story from their facility, to know that this is lending itself to quality improvement and to the improvement in catheter care and prevention of UTIs. Stephanie, I'll just let you take a few minutes to go over this patient story.
Okay, thanks, Jennifer. Everybody can hear me okay?
You're doing great.
Yep, okay, great. Okay, great. Anyway, we had a 79-year-old male present to the emergency department with a chief complaint of vomiting with a small amount of blood present. He was status post last coli 3 days prior. And he had a medical history, which includes he was on meds for BPH. He had a history of reflux and no history of ulcers. A urinalysis was done, and he was positive for moderate blood with 5 to 10 WBCs, 0 leukocytes, 0 nitrites. So it really was not a very impressive urinalysis. A culture was done on admission, which proved to be negative at that time. A bedside ultrasound was done on this patient, and it did show a swollen bladder. A Foley catheter was placed immediately in the emergency department, and the patient did have an output of 2 liters throughout the stay in the ED. He was stable, and he was transferred to our medical unit. 4 days into his stay, he still had his Foley catheter in, and he started having temperatures of 1 and 1.3 unrelated to anything else going on with him. His urine culture did grow out greater than 100,000 of E. coli. And so this story just begs the question, did this patient, even though he did have acute urinary retention, which is an indication for a Foley catheter placement, did he in fact need a Foley catheter immediately in the emergency department, or could a straight catheter have been used as an alternative?
That's great. Thanks, Stephanie. This is just a story that lends itself well to this first pillar of prevention, which is attempting to avoid placing catheters when it's appropriate. And these stories that we're getting from the different facilities, they don't have to be the big train wrecks. They're just good examples of the harms that can occur in the healthcare setting related to infections, and makes us think about, could we have done something a little differently here? So this speaks to our first pillar, and that's trying to avoid inserting unnecessary indwelling catheters. The guiding principle here is that no invasive device should ever be used unless absolutely necessary, because all invasive devices increase the risk for infection. And I'm speaking to the choir when I say this, but you know as well as I know that there's a lot of clinicians, staff out there that don't really see the catheter as all that invasive. They don't think of it that way. They don't see it as a conduit of infection risk like we do. So take a moment and reflect on this. If you did a catheter audit today on your unit, what would you find? What percentage of the patients with catheters meet the indication for insertion and continued use? In one study done by Sanjay Saint and his colleagues, they found that 21% of patients had an indwelling catheter did not have appropriate indication for use. So we're talking about, just in this one study, 1/5 of the patients were put at risk for possible harm related to a UTI. So we don't want to belabor the point, as many of you are quite familiar with the best practices and the guidelines. So here are the highlights in a nutshell when it comes to avoiding unnecessary indwelling urinary catheters. First, you want to make sure that your ordering physician is using explicit criteria when ordering a catheter. Perhaps building that into a drop-down menu if you're using computerized physician order entry or something like that. Secondly, you want to have the nursing staff verify the criteria is met prior to inserting the catheter. Because if not, there should be some sort of agreed-upon protocol or process for what to do next, like to contact the ordering physician to confirm why the catheter is needed and to possibly offer alternatives as appropriate. So the criteria for insertion in just a nice little table format here, and it is when there's perioperative use for selected surgical procedures, and that's selected, and there's a few examples that are given in the HICPAC guidelines, and we can talk about those later if you want. Urine output monitoring, but in critically ill patients only. Management of acute urinary retention and obstruction. And, sorry, my wording's a little off here. So assistance in pressure ulcer healing for incontinent patients. And that's going to be typically when you're trying to heal an open sacral or perineal wound in incontinent patients. Otherwise, incontinence is not an indication. And as an exception, patients who request to improve their comfort, especially as part of their end-of-life care, that can be an indication as well.
Thanks, Jennifer. Before we get to our first hospital story, I think I've jumped in on you.
All right. You go right ahead, Gina.
This slide just gives a little bit in terms of alternatives. What are those alternatives out there? Rather than going straight to a Foley indwelling urinary catheter, certainly bedside bladder ultrasounds can be used to confirm if retention has occurred. And then if there is retention, there is always the choice, or often the choice, of whether to do a straight cath and then allow that patient the opportunity to be able to void again on their own, or using condom catheters as well. The website that Sanjay Singh and his colleagues have put together is www.catheterout.org. Actually provides some additional information on condom catheters and their use. Here's where I meant to jump in with you, Jennifer. Prior to getting to the first of our two hospital stories, I just wanted to mention that Jennifer and I have been out and about talking with folks in hospitals, both in Washington, Idaho, talking with different ICUs that we're involved with, and asking them about their current prevention practices when it comes to avoiding catheter-associated UTI. And for me, there was a bit of a reality check on this particular pillar of prevention, that for many of the ICUs, the focus has not been so much on avoiding placement because a lot of patients come to the ICU with one already in place, sort of precluding the opportunity to avoid putting it in. And that many of those are placed in the operating room or in the emergency department. And some patients are in fact transferred with one as well directly to the ICU. And for me, this just sort of begs the question of, gosh, or the reflection on, for this particular pillar, a facility-wide approach can be pretty impactful. Having the same set of criteria be understood in sort of the same mental model across the facility, education that is rolled out and expectations set across the facility could be very powerful here. In terms of how to start, though, and whole QI, the quality improvement, process improvement mindset, we always kind of come back to the PDSA, or what is the first small step of change one can make. And so I still think even though it's sort of a facility-wide, maybe pillar, the place to start might be parallel PDSAs, parallel tests of change, kicking off in an ICU, kicking off on a med-surg floor, kicking off in an ED, learning what works on each of those floors, and then based on what actually works in real life, that is impactful, to then figure out how to roll that out more broadly. Anyway, I just wanted to acknowledge the fact that this pillar is a little different from some of the others for the ICU crowd. And with that, I would like to hand it over to our first speaker, Stephanie Martin, who shared the patient story a little earlier. Stephanie, take it away.
Okay, so the ladies wanted me to go over a few of the things that we've done in order to avoid catheter insertion at St. Luke's Market Valley. And if we can go to the next slide, maybe one more. There we go. So on all of our Omni cells, right in front of our catheters, you can see that we placed a stop sign and a reminder just to sort of trigger everybody who's going to be pulling a Foley catheter. Does that patient really need it? And the indications for catheter insertion is on there, as well as what it's not indicated for. And even in speaking with some of our nurses, it's been eye-opening for them that they don't realize the correct indications all the time. Another intervention we did is we met with the hospitalists at their monthly staff meeting to discuss the indications and complications of Foley catheterization, as well as encourage them to use the alternative before they even place the Foley catheter, and they have been really responsive in helping us decrease our catheter days. So we're in the process of changing that culture that Jennifer had mentioned previously, and getting our staff to begin to understand that a Foley is not just a Foley catheter, but is another invasive device that can cause complications and infections in our patients. And then one other thing that we do is we give immediate feedback to the managers and educators when the CAUTI is found, so we can review that case with them and keep that spotlighted, as well as posting for the staff to see their infections, so we can keep them engaged in trying to get the catheter to not even be placed in the first place.
Thanks so much, Stephanie. Just as a reminder to all, we will, after our next speaker, be opening up the lines for questions and for discussion. So if you're holding on to a question or interested in how the nurses received that intervention, if there are any tweaks along the way, what kind of questions maybe the hospitalist had, we can make time for that in a moment. Next, I'd like to hand over the phone, so to speak, to Jayla Langley. Jayla comes to us from Yakima Valley Memorial Hospital, where she heads up their infection prevention and control efforts. Jayla, take it away.
Hi, this is Jayla. I'd just like to thank you all for taking the time to participate in these webinars. I think this is a really great opportunity for collaboration on a subject that has a significant impact on our patients and their safety. Our efforts really started with our participation with NHSN, or the National Health and Safety Network. We started to collect and submit data for CAUTI, CAUTI, and VAPS, and this kind of really gave us an excellent resource for identifying areas for improvement and monitoring the success of implementing those changes. We have done a couple of different things, and I guess where we started was with our work with NHSN. We really focused our efforts to begin with in our CCU. Some of the things that we did were implementing daily rounds that really kind of started talking about addressing the need for indwelling devices during those rounds, and of course catheters were a big one. So kind of getting the conversation started of what really is an indication for catheters. We also developed a clear and easily accessible policy and procedure that covered the indication for use, the CAUTI prevention bundle, retention catheter care, insertion removal, and how to collect a specimen, and really reinforced that we really have to have a need for a catheter. It shouldn't be for convenience. It shouldn't be just because, someone needed to collect a UA, so they placed one. Staff education was huge. We had posters, email reminders, inclusion in the skills fair. Each unit has their own educator, so we utilize them for periodic education reminders. And then, of course, with our participation with NHSN, we do targeted surveillance with case review by the Indwelling Device Committee. Monthly and quarterly reports are given to the Infection Control Committee and the Performance Improvement Steering Committee. And those reports also go to administration and our Board of Trustees. And we also post the results for infection rates on our CCU scoreboard to share with staff. So I think the more that you can get people realizing kind of what they had said before, a Foley is not just a Foley. It's an actual indwelling device that can have negative outcomes for our patients. Another thing that we've done is over the last couple of years, we have started taking a service line approach to quality improvement, and this has really had a huge impact on process changes outside of CCU, because as you all know, I'm assuming most hospitals, and this is how we are, most of our catheters are placed in the ED or in surgery. So how do we affect those areas? So part of our service line approach is we actually have an administrative director of critical care. So our CCU, ED, and respiratory care all report to her. So when we have implemented changes or identified, hey, we need to decrease placement, we have someone who looks at coordinating how that patient will, how that care will look from the time the patient hits the door until discharge. So it's kind of coordinating everything. So you don't have to go to many different people. You kind of have it centrally located. We also have an orthopedic service line director. So we had a huge push for step improvement, which included removal of the retention catheter by G2. When we implemented 24-hour stop orders for all the surgical patients, except when there's an indication, we had a huge physician education piece that went on. And as a result, we saw a great reduction in the placement of unnecessary catheters in our surgical patients. So they're trying to really only place catheters in patients that really need them for those specific surgeries. We also incorporated catheter present with a link to indications in the head-to-toe section of our electronic medical record. So once again, making it just really on the top of everybody's mind. If the catheter is there, we need to get it out, and these are the only indications that it needs to stay in. And one of the big resources that we use for a lot of our policies and procedures and kind of getting some ideas is from the APIC 2008 Guide to Elimination of Catheter-Associated Urinary Tract Infections and the IHI website. So if any of you are looking for good resources, those were two that we found pretty helpful. So I think that's about it. Thank you.
Jennifer, let's move on to the next slide. I wanted to go ahead and shout out a great big thank you to Stephanie and Jayla. It's really helpful to hear about what's actually happening in the hospitals and tools and tricks that your peers on the line could use. I really like that you were talking about the ER and the OR placement there at the end, Jayla. As I was reading a little bit more about that earlier and saw a study that revealed the majority of catheters are not even inserted on nursing units. That in one study, 37 were placed in the emergency room and 29% were placed in the operating room. And that's what I heard on a lot of my site visits to the different hospitals was that, we're not placing a lot of them. So, what may come in handy is the rest of the series, but in terms of when they're already placed for you. But, so thanks for bringing that up. And as I was looking and thinking about, when and how they're placed in the OR and you have your physicians who are scaling back on that, if you have, and I can ask this of anybody on the line, I want to make sure Alicia is opening up, taking the mute off the line so we can start talking a little bit right now about this and other parts of the discussion that you've heard. So one of the things is, do you have any guidelines for your surgeons around what they should be following for indications for surgery? Because I'm looking in the HICPAC guidelines, and they have patients undergoing urologic surgery or other surgeries on the genitourinary tract. If there's surgeries that have an anticipated prolonged duration, there's not a time for that, and it says the catheters inserted for that particular reason should be removed in the PACU, so immediately. If they're only put in for that reason because it's going to be a long surgery, they need to come out. Patients who anticipated to receive large volume infusions or diuretics during surgery, that makes sense. And if there is a need for intraoperative monitoring of urinary output. But I didn't know if you had any. Does anybody on the line have specific guidelines they've developed around that?
Ladies and gentlemen, the lines are open, and you can press *6 to mute or unmute yourself.
And anybody can feel free to talk, and it's all right if you don't have much to say right now. We'll keep going, but think about that. Think about any developments you've had in the ER and the OR in changing the practice of actually placing or not placing the catheter.
For our facility, I believe that we did get those from the IHI website. That is basically we just kind of copied it right down and put it in posters. And the big thing was the 24-hour stop orders. Is once we started kind of talking to our physicians about implementing those changes, and that every 24 hours they would essentially have to reorder the catheter, they kind of started asking for information on, okay, well, what exactly are the indications, and kind of took that upon themselves. I think, to be honest, in part, it was kind of a hassle to them to have to be reordering those or getting calls from nurses about reordering catheters that shouldn't have been maybe in the first place. And so I think for them it was kind of a convenience issue, to be honest.
And Jayla and Stephanie, this question would be posed to both of you, so think about it for a second. It's really simple. What kind of pushback did you get when you started talking to your physicians about avoiding use or looking more closely at indications. So what kind of pushback did you get from them? And what kind of pushback maybe have you gotten from the nurses about questioning physicians?
Well, I could start with that. You know, some of the pushback that we got from both physicians and nurses were that this is we have patients who ask for them, or this is really a patient choice, and you know, we have some of the pushback with nurses is, you know, we're really busy, and this is one more thing that you want us to go to the doctors about. You know, they're ordering it. And so really our focus has really been to try to have the focus be on this as a patient safety issue. Everything that we do at our organization is for the safety of the patient. And so really getting that emphasis down and really pushing this, that patients, even if they're saying, hey, I want a catheter, do not necessarily understand the ramifications of, you know, it might be convenient for a while, but there's a whole lot of things that can happen with unnecessary catheters, with increasing infection risk, increasing fall risk. There's a whole host of things. So just really trying to remind staff that these measures and these things that we're trying to put into place are all about patient safety and making sure that the patient is as safe as possible. And with that, I mean, I think the more that time goes on, maybe there's a few students who talk about catheters more, but they seem to be more accepting of that with, okay, this is a patient safety driven item, and so we need to embrace this.
So, Steph, thank you, Jalen. Stephanie, I know when we were talking about when you took the sign that you're putting on the Omnicells and the encouragement you were giving the nursing staff to just be aware of the indications before they're placing a catheter, and you took it to the hospitalist, what was their response when you said, we're going to do this soft approach of having the nurses think twice as they're grabbing the Foley kit? And you might have to unmute your phone if you've muted your phone, Steph.
Am I unmuted now?
You are unmuted now.
Okay. Anyway, sorry, I tried doing that earlier, you guys. The physicians at first kind of, rolled their eyes. It's one more thing we're throwing at them. But I did the same thing that Jayla did, talk about patient safety and what's best for the patient. They had a few arguments when they are going to be on a diuretic, that the Foley is important, they thought, at that time. And I tried to respectfully understand their position, but again, went back to the safety of the patient, what's best for the patient at that point. And then another argument was for skin integrity. And basically, I showed them that study showed that if somebody is incontinent at home and they come in and they're incontinent at the hospital, that the likelihood of having increased risk for skin integrity issues is not any higher. So they seem to buy that. And then one of the other things that we implemented that none of the physicians like, but it has also tremendously helped with our device days house-wide, was we have a stamp in every single person's chart who has a central line or a catheter is stamped daily that the physicians have to sign of whether or not they want to discontinue it or continue it with a reason. And they have to pick which reason they want. And like I said, that doesn't make them very happy, so they're actually telling me that they hate the stamp, so then they just pull the catheters, which was fine by me.
Great. Thanks, Stephanie. I like how you guys are giving us your examples of how you avoid catheters, but it does tie to your efforts around removing catheters, too. So it makes me think about Dr. Dale Bratzler, who many of you are familiar with. He's a guru of all things core measures, all things SCIP, National Quality Forum, et cetera, and is a big proponent, of course, of SCIP 9, getting those catheters out. But he said that the best thing that you can do to prevent UTIs besides getting them out is not putting them in. And I like that. It's simple and it makes sense. But so with these things in mind, I want to also just make sure that everyone on the line realizes that if you have something that you want to add to this topic, how you're avoiding catheters or how you're using alternatives for catheters, if you have products that you're using to absorb your incontinent urine, if you have anything that you're doing working with your ORs and your ERs, I invite you right now to go ahead and just share a minute because you're sharing with your peers and they could use your help. And if you're muted, you may have to unmute yourself. Okay, we have some quiet attendees. That's okay because that just means that we picked a couple of hospitals that had some tools and we're able to share with some folks who could probably use some of that advice and some of those interventions. So kudos. I guess this question, what excited you about what you heard? That could be one that somebody on the line could go ahead and unmute and say, what excited you about what you heard? About what is there something in there you can kind of sink your teeth into and do at your own facility? Or sounds like something that you've been wanting to try at your facility?
This is Cheryl at Deaconess.
Hi, Cheryl.
I think, talking about most of them being inserted in the ER and in surgery really strikes a note. I know we have a similar thing here, but maybe even taking a look at what the quantity is so we can look at or doing some spot checking on what the percentages are at our own hospital on that so that we can focus some education in those areas for good insertion practices. And I also really like the poster, which is an easy implementation around here. I mean, we have a similar.
And Benjamin Carson,
make that up for our hospital fairly easily and implement that outside. So that sounded exciting.
Great, thanks, Cheryl.
This is Tina. I'm just going to jump in because I was really struck by both speakers, and I think Cheryl kind of was getting to it just now, that the poster itself is a great visual cue and kind of elegantly simple as far as placement to the right by the kids. That is one thing you could do by next Tuesday. Very simple, straightforward visual cue. The other things we heard about might, in terms of implementing, might depend on the infrastructure and the setup you have at your hospital. I'm not sure how many hospitals have indwelling device committees. That sounds like a pretty cool committee to have, one where you're not just talking about central lines, we're just talking about CAUTI. It's not all split up, but thinking about invasive devices altogether. So for me, I thought, wow, cool, simple, straightforward visual cue idea. And then also some pretty interesting thoughts around service line, around indwelling device committees, around building infrastructure to support that culture of just indwelling devices or invasive devices being sources of infection, and hence all of them are important to look at. So thank you so much, both Stephanie and Jayla, for that really broad view on different ways to approach it.
Let's go on to that next question, Tina. And we're kind of in the process of answering that right now, and we can hear from some of the others, but what do you want to try? What is your facility? What do you want to try in your facility next to avoid unnecessary insertions? And just using some of what you've heard today as ideas, like Tina was saying, and like Jayla was saying, you could go very quickly to a poster. You could go very quickly to a conversation with your director. If you have a setup like Jayla where it's the director of the ER, CCU, and respiratory, you may not have that, but you may have the relationship with those people as well. And to have a conversation. I was visiting with the infection prevention and stuff in CAUTI, and I think we have one of them on the line. And just to mention in passing, we were, doing a site visit and just talking about their program there. And even though it wasn't a formal intervention, there was an informal intervention of a conversation with some key folks in the ER about the placement of Foleys before they come to the ICU. And they were able to, just by communicating with one another, able to reduce some of the placement that was occurring that may not have been necessary right at first in the ER. So kudos to them. I wanted to mention that. Does anybody else want to talk about what they think they'd like to try next to avoid unnecessary insertions? Do I have anyone in the eastern part of Idaho? See, I'll start calling on people. You got to be careful. All right. Well, let's go down to the last question, Tina, because I think this is one that a lot of people will have some voice on. What might get in your way? So all of you are thinking about something that you can do. A lot of the programs we've seen have some great insertion programs for prevention, maintenance prevention, getting that catheter out, and we can all build our strength around avoiding unnecessary insertions. But what do you think is going to get in your way when you focus on indications? What do you think is going to get in your way when you need to address that topic or hang those posters or try that PDSA in your ER? Who's going to get pushed back and who are you going to get it from? And is there a leadership piece to it?
This is Cheryl again at Deaconess. I can tell you where I've gotten it already.
Great.
I've gotten and had to make some compromises with our anesthesia team who we have a population of oncology surgery patients that have an extended time with an epidural for pain management. Mm-hmm. And they frequently will see urinary retention related to that, so they're reluctant to pull the Foley after surgery, even though these patients are ambulating. But their pain relief, is significant with the epidural in place, so they want to leave the catheter in until the epidural is taken out. So that's one ongoing discussion that we've had. And the other one, just yesterday morning, I believe, came from the neuro group talking about, significant diuretics being used outside of the ICU and the need for their perceived need for these Foley catheters with this continuous urine output on these patients for their need to keep their bladders draining without having them be up at the bathroom every 10 minutes. So those are the two major pushbacks I'm getting.
Thanks, Cheryl, for sharing those. That's great feedback on some of the things that can get in the way, and I like that you use the word compromise, and some of the compromises you have to make as you're going down this road. And it's true that it's important to consider that when fewer catheters are used, there's going to be implications on nursing personnel time and resources. And patients might need more regular checks for assistance, accessing the toilet, and that can even be a cost-efficient cost. There we go. So there can be some pushback from your nursing staff who know it's going to cause a little bit more work, getting the patient up and around and getting them assessed and in the bathroom and such. So let's move on to the next slide. And Tina, I'm going to hand it over to you.
All right. So as I mentioned at the top of the hour in terms of agenda, we really want to always start with the patient story. We want to always end with an opportunity to discuss as well as to actively make requests or offers to one another. And that can be as simple as, hey, could I get so-and-so's contact information? Or, for example, today Jayla mentioned that they had a policy and protocol that was all-inclusive around indwelling catheters. If that is something that's of interest to folks to see, a very obvious type of request would be, gosh, would you be willing to share that with a larger group? Another opportunity here is if you are a facility that's just got great infrastructure going on here and are getting great results in terms of getting to zero on CAUTI, this is an opportunity for you to share tools you found helpful, resources you found helpful, articles you found helpful. So I'd like to open up again to those on the line to step up, and if you have something you'd like to ask for or share, to use this time now.
This is Jennifer. I'd also like to add to that. While you're thinking about it, there's something more that I want to ask for on this particular topic. But we'll definitely be sending you some of the resources that were referenced in Jayla and Stephanie's presentation. In the spirit of sharing, they're willing to do that. And also just know that any great tools that we get our hands on, we'll send your way. If there's anything in this particular realm of avoiding inappropriate catheter use or, following indications, if there's something that you feel like was missed, please volunteer that. Like, well, what about this? Please feel free to throw that out there because there could be somebody else on the line that could help, answer that question with something that they do.
Hello, this is Mike Mint from Virginia Mesa in Seattle.
Great.
And I was just rounding in the hospital here, and we had a patient with morbid obesity and a hip-related issue, and it's challenging because it doesn't have any skin breakdown, and so there was the discussion actually as I was running down here to listen to this conference call between the nurse and the hospitalist, and this patient was a 4-person assist to move. And really wasn't participating in her health care very, very frequently, so had some other incontinence issues and things. And so just wanted to throw that out there and see what folks thought about that particular case, Foley catheter, indication or not, and how did you handle it?
Thank you so much for giving us this opportunity to talk about an ongoing case. That's pretty exciting. I was just going to ask this really, really simple question. And one part I missed, did she already have a Foley in, or are they trying to decide?
Oh, sorry about that. She actually did have a Foley catheter in place prior to arriving at our facility.
Oh, prior to arriving.
Yeah, so this wasn't so much a question of placing versus not, but it's sort of the same question. I think this question would have come up regardless if she had a Foley catheter in place or not.
This is Tina, and while folks are thinking about how they might approach that situation or what they might like to share, I'd say, gosh, it sure strikes me as like what the trade-off. What is the trade-off, and where is the best position there? Certainly challenging to maintain hygiene with a 4-person assist. But similarly, for someone who is obese, their reserves if they get an infection are not great. So I can see how that would be a tough choice in terms of trying to think about, from a patient safety perspective, how to keep the patient from an adverse event. If we do not hear from other folks, if you're willing to share sort of where that conversation left off, that would be of interest.
We have a lot of infection preventionists on the line. I would love, even if somebody doesn't have the answer, if you have part of the conversation or if you've experienced this before, we would love to hear it. This is just a great opportunity.
Hi, this is Karen from Capital, and I can tell you from my experience that you're going to lose that battle in the Foley will.
Thanks for that input. That's real.
Can you? this is Mike again, and I can kind of go into that, what that discussion was like. Like I said, I left kind of right when it was ending there, and as the prior speaker mentioned, the hospitalist left that particular round, and the hospitalist was very correct. I mean, the hospitalist was mentioning risk of infection and talking this through. But what I did not hear was sort of that risk-benefit discussion. You know, we tend to have these kind of almost parallel conversations to the nursing staff, and not really sort of focusing it back on the patient. And so, what I tried to do when I was leaving was to say, look, let's continue this discussion, because I think it should be an ongoing discussion and an ongoing risk assessment. I will share. Well, actually, I guess we're going to talk about removing catheters at a different conference call.
We are, but you can
go for it.
You can talk about it. Yeah, that's fine.
So anyways, the one other thing that we have in our electronic medical record is that it will continuously ask the hospitalist every single day to choose an indication for the Foley catheter to remain in place. And so actually, the hospitalist, I think, is reacting to our prompts in our electronic medical record appropriately, and so hopefully this will be an ongoing discussion, an ongoing risk assessment. But I do think that it is a challenging case, and I certainly understand from the nursing's perspective that they're worried about the wounds happening. This patient has an acute hip issue, and so actually this patient was much more mobile prior to this event that brought her into our hospital, and so hopefully as we start to resolve that issue, we can keep readdressing the Foley catheter. But that's where we left it.
Thanks, Mike. This is Jennifer, and I'm just kind of looking at these indications again, kind of a little deeper in the HICTAC guidelines, and one of the appropriate indications, and I don't know if she falls into this, is when the patient requires prolonged immobilization. Of course, the examples they give are pretty severe, like potentially unstable thoracic or lumbar spine, multiple traumatic injuries such as pelvic fractures. I don't know if that would apply in this case, and I don't know if we want to look for it to apply, but it could be that if there is prolonged immobilization, if that's an issue, I think that's the gray area, that where the indication might be there. But also, I'm kind of reflecting too on, did this person come from home? Did they come from an LTAC? Do they normally have an indwelling catheter in another setting, in a care setting, or an LTAC or something? We have a couple of LTACs on the line. I know that, and they are more than welcome to comment on this, because they probably run into things like this as well. So just a little bit of input there.
Jennifer, this is Aline Lee at St. Alphonsus in Boise.
Hi, Aline.
Hi. I think the win here is that the conversation occurred at all.
Right.
Because we've had conversations here, not lately, but in the near past, where the doctor doesn't even know that the patient, whether they have a Foley or not. It's just hasn't been an important thing. It hasn't. So I think that's the win. And there are always going to be cases where it doesn't fit all the rules.
Too tough, yeah.
But the conversation is occurring to determine what is the best thing for the patient. And I think there will always be those gray areas.
This is Tina, and I just wanted to jump in and say I think that's a great point, and that when we're talking about putting in infrastructure, policy, protocols, having a shared mental model, it really is so that you have those in place for the 90% of the patients that are going to fall into that framework. There will always be those gray areas, but that's not the vast majority of the patients. Those are not the vast majority, like the patient Dr. Mint brought up. They keep the conversation going, and they challenge us to focus in on what's best for the patient. And it's great to have the time and energy to then talk about those individual aberrant cases. But the ideal is to have that infrastructure and shared mental model in place for the vast majority of all the other patients, where it's a much easier call. And I guess I want to just bring us back to thinking about the 80-20 rule, the 90-10 rule, that we should not we should avoid getting stuck by those ones and twosie cases, and we should be moving forward with the larger group of patients where these things apply. But that would be my little takeaway from that.
So thanks, Elaine, for bringing us back to also recognizing that the patient safety culture, the evolution of the patient safety culture in each person's setting is at a different place on their spectrum. And I really appreciate that you brought us back to recognizing that the conversation actually took place and they were sharing and communication and patient-centered care around that person. So thanks. Tina, should we move on?
I think we should. So if things come to mind, things you'd like to request from the group at large, or things you'd like to distribute to the group at large through Jennifer and I, please note our email addresses here. And I'm sure you have them because we've been contacting you throughout the last number of months. Don't hesitate to contact us, and we will disseminate. We'll be the middleman to make that all happen. Or the middle women, as the case may be. Yeah. This is my pitch for a really great website, and it is also around exchanging information. AHRQ has an Innovations Exchange website. I've pitched this pretty hard, I think, to a lot of the folks that I've met with here in Washington. And what it is it's a great site that's about all sorts of different topics and subjects in healthcare, and it features basically what I would call implementation stories of healthcare facilities and different settings, how they've approached that issue, what they did, how it worked, and adoption considerations for other facilities. And so I bring it up for two reasons. One, it could be a great place to go looking. If you're looking for some inspiration or some innovative ideas or some tools, it might be a place you would find things. It's also a great place if you, in fact, as a facility, are having some success with a particular implementation or a particular intervention. It's a great place to share your story, not only from maybe leadership perspective of finding some good PR, but also in terms of sharing that wealth of knowledge and helping those across the states in terms of this journey towards reducing HAIs. With that, I'd like to just transition into thinking about our next time together in a webinar. 4 webinars. We're coming close to the end of the first one. Our next one is all around insertion, inserting aseptically and good technique. That will be on February 16th, 1 o'clock Pacific time, 2 o'clock Mountain time. And we're excited about that coming up. And we really appreciate you joining us here today, particularly for all those folks who are battling the snow today. And if it was hard to find time to squeeze us in, we really appreciate that you made the time. We also want to take another moment to say a big thank you to Jayla and Stephanie for their generosity in sharing what's going on at their facilities and the good work that they're doing. So, Jennifer, I'll hand it to you to say your thank yous as well.
Thanks, everyone. I know you need to get off the line. Last shout out is we will email you a link to the archived recording, copies of all the materials that were offered in today's exchange. And we will also probably be picking your brain for our next patient story and for those people who want to highlight what they're doing on insertion practices. So don't be surprised if we start talking to you about, hey, let's get you in on this next webinar. Be sure to complete the survey at the close of this webinar so that we can make sure that we're always improving what we offer to you. So with that, have a really good rest of the day and safe travels in the foul weather.
Thanks so much, everybody. Bye-bye.